Hi, Dr. Caroline Abercrombie here with ETSU, Quillen College of Medicine. This video series will cover the superior and posterior mediastinum. Part 1 will look at the superior, and then the second video will look at the posterior mediastinum. Make sure you watch both videos to get a complete understanding. The goal is to eventually be able to form a three-dimensional understanding of the mediastinum. We've talked about the middle, and now we're going to discuss the superior and posterior, but at the end you need to go back and try to put it all together. You're going to see some of the same structures appearing as we go through the different divisions. That's because they're vertical structures and they're going to travel through all these different divisions. But as they travel, the relationships change. And so it's important to understand that because that's why we actually divide the mediastinum into the different divisions. Knowing these anatomical relationships will help you better understand the disease processes that affect the different structures and why you get different patient presentations. So let's start by looking at the borders of the mediastinum as a whole. Superiorly, we have the superior thoracic inlet. The superior thoracic inlet is just the bony entrance to the thoracic cage. It's formed by the clavicle, the thoracic vertebra, and the sternum. Inferiorly, we have the diaphragm. Anteriorly, the sternum, and posteriorly, the thoracic vertebra. We divide the mediastinum into superior and inferior divisions using an imaginary line called the transverse thoracic plane. This plane is located at the sternal angle and thoracic vertebral level TV4-5. Remember the lateral borders. That was the mediastinal parietal pleura. So we're going to be looking at the structures in this red area between the boundaries of the mediastinum but above that transverse thoracic plane. So let's look at the contents. These are listed from anterior to posterior. So the thymus is going to be our most anterior structure. And just behind the thymus, we have the brachiocephalic vein. So here you're going to see us use this VATE relationship. This is going to come up quite a bit. V-A-T-E. V for that brachiocephalic vein. A for the aorta, its arch and its main branches. T for the trachea. And E for the esophagus, which would be the most posterior of those. We're also going to discuss the nerves that travel through the superior mediastinum, the phrenic nerves and the vagus nerves. And then we'll end with lymphatics, specifically the tracheobronchial lymph nodes. Here you see an anterior view of the thoracic cavity. The chest wall has been removed, as well as the anterior parietal pleura, more specifically the anterior costal parietal pleura. And if we put a line here, you can see about where the transverse thoracic plane would be located. So we're going to be looking at the area above this transverse thoracic plane, between the mediastinal pleura, and inferior to the superior thoracic inlet. The first and most anterior structure we're going to discuss in the superior mediastinum is the thymus. So in this image you see that it looks like a collection of fat. In an adult that is accurate. In the newborn it's an active lymphoid organ. But as you near puberty, it involutes and becomes just a mass of connective tissue and fatty tissue. And so it's very difficult to see in your adult patient when you do the dissection, and it often comes off attached to the thoracic wall. As we move posteriorly, we need to look at the VATE structures now. So again, remember, anterior to posterior, we have V, A, T, and E. Now, something I want to emphasize. You will only see this relationship in the superior mediastinum. Therefore, if you're looking at a cross-section and you see a brachiocephalic vein, the aorta, the trachea, and the esophagus in this anterior to posterior relationship, it has to be above that TV4-5 level because it's in the superior mediastinum. Looking at a lateral view with the lateral chest wall removed, we can again look at the borders of the mediastinum and then try to identify the VATE relationships. Superiorly, we have the superior thoracic inlet. anteriorly the sternum, posteriorly the thoracic vertebra, and inferiorly the diaphragm. Again, laying down our transverse thoracic plane, we look superior to that line for that vate relationship because we're only going to find that in the superior mediastinum. So V is the most anterior of the vate relationship. But do not forget, we still have the thymus collection here, just anterior. So the brachiocephalic vein is just in front of the aortic arch and its branches, easily visible here. The T is not as easy to visualize in this image because the aortic arch and its branches are hiding it. This arch is a posterior lateral arch. If you look at the root of the lung, you can see where the main stem bronchus is, and you can imagine that the trachea would be right in this area as it descends from the neck to the carina where it's going to divide. You can see the esophagus in this view, and it would be just behind that trachea, but again, anterior to the thoracic vertebra that make up the posterior border of the superior mediastinum. Remember, that's marked here with the blue line. Now let's look at it in this view, a cross section. Now when we read cross sections, we read them just as we would with a CT scan. We look at it as if we're standing at the foot of the patient's bed. So we're standing at their feet, looking superiorly towards their head. That means the patient's left is now going to be on our right. So this is actually the left lung that's on our right. And so this would be the patient's right lung, which is on our left. Again, let's look at those borders of the superior mediastinum. Anteriorly and posteriorly, the sternum and the thoracic vertebra. Laterally, the mediastinal pleura. So let's find that vate relationship. Again, the thymus just behind the sternum. And then V for brachiocephalic vein. A for aortic arch and its branches. Here you see 3 different A's. That's because we're a little above the arch, where the 3 main branches are coming off the arch. As we continue to move posteriorly, we have the trachea. Remember, I said the aortic arch is a posterior lateral arch, and it's a posterior lateral arch towards the left. And so not only is the aorta and its branches going to be anterior to the trachea, but they're also going to be to the left lateral aspect of the trachea. And that's much easier to see here in this cross section. And then just behind the trachea, we're going to have the esophagus. So let's look at each one of these vate structures independently and discuss the structure as well as its anatomical relationships. V, the brachiocephalic vein, comes first because it's most anterior. The brachiocephalic vein is formed when the subclavian vein and the internal jugular vein merge. So let's first look at the left brachiocephalic vein. The left subclavian vein drains the arm, and you can see it here as it dives over the first rib to enter thoracic inlet. As it enters the thoracic cavity, you can see that the internal jugular is going to merge with it. This occurs at the sternoclavicular joint. And that is where we have the origin of the brachiocephalic vein. The brachiocephalic vein on the left will then continue to cross midline to meet up with the right brachiocephalic vein. The right brachiocephalic vein is going to be formed when the right subclavian vein and right internal jugular vein merge to form the right brachiocephalic vein. Notice I said internal jugular. That's because the external jugular comes into the subclavian vein just a little proximal to where the internal jugular meets. So once we've formed our brachiocephalic veins, they're going to merge to form the superior vena cava. Now, realize that left brachiocephalic vein is the one crossing midline, so it's going to be quite longer than the right. And this origin of the superior vena cava is going to be found just to the right of midline, and actually just to the right of the border of the sternum, what we call the right parasternal border. And it happens at the first costal cartilage. So the superior vena cava forms on that right parasternal border at the first costal cartilage and then descends down to the third costal cartilage where it dumps into the right atrium. So next we have A. In this image, you can see how the aorta does tuck in with its branches just behind the left brachiocephalic vein. So let's look at that a little closer. This is an anterior view of the heart, and you can see the aorta is the only colored structure here. V is the transparent brachiocephalic vein coming from the left to merge with the right brachiocephalic vein and eventually form that superior vena cava we just talked about. But just behind it is where you're going to have the aortic arch and those three main branches. So where does the aorta receive its blood? The left ventricle. So left ventricle pumps oxygenated blood into the ascending aorta. The ascending aorta is a very short piece of the aorta, and as soon as it starts to arch, then we enter the arch of the aorta. It then moves posterior laterally, like we've already talked about, and then eventually descends and becomes the thoracic descending aorta. We have a few branches we need to discuss while we're here. The ascending aorta is very short, but it does actually have a couple branches, and they can be seen sketched on the heart here as the coronary vessels. The left and the right coronaries both come off the ascending aorta. Right as the blood leaves the left ventricle and passes through the aortic valve, it's going to hit that ascending aorta, and that's immediately where you're going to find the coronary arteries. Then the arch begins, and we have our three main branches. And medial to lateral, you can see those labeled. First, the brachiocephalic trunk. As we move laterally, then we have the left common carotid artery as the second branch, and the left subclavian artery as the third branch. Notice the right common carotid and right subclavian arteries have a common origin off of that brachiocephalic trunk, while the left common carotid and left subclavian have independent origins of their own directly off the arch of the aorta. This makes sense because the left and right common carotid supply the head and neck, while the left and right subclavian arteries supply the arms. The head and neck are more medial to the arms, therefore the vessels supplying them are going to be more medial as well. Then we move into the descending thoracic aorta, and it has a variety of branches, some that we've already spoke of. The posterior intercostal arteries, which are going to supply the intercostal spaces and body wall, will be coming off of the descending thoracic aorta. We also have a couple visceral branches. We have the bronchial and esophageal branches. So here in this image, let's see if we can locate some of the structures we've discussed up to this point. We need to start by orienting ourselves. This is a posterior coronal view. It's a CT that's been reconstructed, and the patient's been giving IV contrast. So all the vessels are going to light up white here. Anything with blood in it lights up white. Here, labeled with number 6, this is obviously the aortic arch. You can see it arching posteriorly and to the left, and then descending inferiorly through the thoracic cavity. You can also see its three branches. Now we talked about medial to lateral, so see if you can label B, A, and C. B would be our brachiocephalic trunk that will eventually feed our right common carotid and right subclavian arteries. A would be our left common carotid, and C, our left subclavian artery. Now, just inferior to the aortic arch, you're going to see G and H. So I just want to bring this back up since we discussed this with the heart. Do you remember what arched underneath the aorta as it left the heart? Those are our pulmonary arteries. So the pulmonary trunk is coming up out of the right ventricle and then dividing into right and left pulmonary arteries to feed blood into the lungs. So here you see the most posterior chamber of the heart. That's going to be the base of the heart. That has to be our left atrium, therefore. Where does our left atrium receive blood from? You see it here, labeled E and F. Those are our pulmonary veins. You cannot easily see all four in this image, but we know there's 4. Right and left, superior and inferior pulmonary veins. J notice, is the most inferior surface of the heart. So that's the chamber that's forming the diaphragmatic surface of the heart. So that has to be our left ventricle, which is going to eventually feed the aorta. Let's look at structure 5. That is our superior vena cava. The mass that's compressing it is preventing the blood from the superior vena cava from draining into the right atrium. So what is M? M is going to be a vascular structure because it's lit up white from the IV contrast, so we know that has to be vascular. This is a pathological structure. And it looks like it's coming off this area D that is actually the ascending aorta. So this is an ascending aortic aneurysm. This is why we need to understand anatomical relationships. An aneurysm here on this ascending aorta is compressing the superior vena cava. So what does the superior vena cava drain? The brachiocephalics, which will be draining the internal jugulars and the subclavians. You're going to learn how to take a jugular venous pressure. You would expect to see that increase in this patient because the increase in pressure in the superior vena cava is going to be relayed back to those vessels that are tributaries to that superior vena cava. By tributaries, I simply mean these are vessels that are draining into the superior vena cava. So I'm saying the brachiocephalic vein is a tributary to the superior vena cava, and the internal jugular and subclavian are tributaries to the brachiocephalic vein. In addition to having aneurysms of vessels, you can also have stenosis of vessels. Coarctation of the aorta is one example of a stenotic lesion to the aorta. And here in this example, you see coarctation has occurred after our 3 main branches of the aorta. Anything proximal to that stenotic area is going to have increased flow, while anything distal would have decreased flow. What does that mean clinically? Well, let's think about this. Increased flow to the 3 main branches off the aortic arch. Those are supplying our head, neck, and upper extremities. If you assess the upper extremity pulses or blood pressure, you may see that they're increased. The lower extremities, however, would be decreased because they're distal to that coarctation and they're fed by the descending thoracic aorta. Well, let's think about other vessels that may have decreased flow because of that stenotic lesion. The posterior intercostal arteries. Those are branches off the descending thoracic aorta. However, recall we talked about collateral flow. They can be fed by the anterior intercostal arteries, which are branches from the internal thoracic artery. Luckily, the internal thoracic artery comes off the subclavian, one of those main branches from the aortic arch, so it's going to already be having increased flow. Therefore, that increased flow through the internal thoracic is going to increase the flow through the anterior intercostal arteries, and then eventually even feed those posterior intercostal arteries because of that collateral flow. One thing we possibly could see after prolonged coarctation is notching of the ribs. The notching occurs because that internal thoracic artery has so much extra flow it continues to dilate and push on the ribs and costal cartilages, eventually to the point to where it's going to even notch the ribs when you look at them on x-ray. Now that we've looked pretty closely at the A, let's look at T and E. This is an anterior view and the heart has been removed, which makes it much easier to see the trachea and the esophagus. You can still see the distal part of the aortic arch, so you can kind of appreciate where the heart was and how the aorta arched anterior to that trachea. The trachea, located here, is made of incomplete cartilaginous rings. The rings are C-shaped, actually. And the incomplete area of the C is the posterior wall. And that posterior wall is going to be closed by a smooth muscle. The smooth muscle is known as the trachealis muscle. The cartilage helps keep the airway open or patent. The flexible posterior wall that's made up of smooth muscle is going to help us when we try to swallow food. So this posterior tracheal wall is very intimate with the esophagus. Embryologically, they actually develop from one tube and then divide into the two. So when you're doing the dissection, you're going to see there's a lot of adhesive bands even between them. The esophagus is going to transit food all the way down to the stomach. And so it's going to need to stretch at times. Since we don't have cartilage on the posterior wall and we instead have that smooth muscle, the trachealis muscle, we have the ability to allow that esophagus to expand and let that food bolus pass. So here you see the esophagus, and follow it inferiorly as it passes all the way down just beside the aorta. It continues inferiorly, but the trachea does not. The trachea ends here at the carina, right at the level of TV4-5. What does that mean? That means the trachea is not going to be present once we go below the superior mediastinum. It's already split into primary bronchi at this level. So let's look a little closer at the main stem bronchus while we're here and we have this image. Notice the right main bronchus is wider and shorter, but it's also more vertical. So when we swallow something and it goes down the wrong pipe, as we say, it's more likely to go down the right main bronchus. So aspiration pneumonia, swallowing a foreign body, such as a small child would do, you would normally look for this to be located on the right side. If you continue down into the lobar bronchus, you'll see the superior and middle and the inferior. But notice the inferior is even more upright. So the lower lobe on the right side is most prone to aspiration pneumonia for this reason, because it's a direct pathway vertically into that right lower lobe. So here again is this anterior view of the thoracic cavity with the chest plate removed. Try to locate your vate structures quickly. Our brachiocephalic vein, the aortic arch with its branches, the trachea, and you can barely see the esophagus sketched here behind the trachea. But what else do we have in this area? We mentioned some nerves earlier. Here, notice the nerve descending from the neck into the thoracic cavity. As it descends, it passes between the subclavian vein and artery and underneath the first rib to enter the superior mediastinum. Notice it's just medial to that mediastinal pleura. And then here, right where the black arrow is, you'll notice it's passing anterior to the root of the lung. As it continues to descend, it will be very intimate with the pericardium. And you can follow it all the way to the diaphragm. This is our phrenic nerve. Do you remember what artery travels with our phrenic nerve? The pericardicophrenic artery, a branch of the internal thoracic artery. Not a terminal branch, but a branch of the internal thoracic artery. The internal thoracic artery will continue distally into two terminal branches. One that we've already discussed slightly, the musculophrenic artery to supply the diaphragm. The second, the superior epigastric artery. We'll discuss it a little further when we get to the anterior abdominal wall, because it's what's going to continue onto the abdominal wall to supply some of our ab muscles. The other arrow is indicating a second nerve. This nerve also, notice, descends from the neck between the subclavian vein and artery to enter the thoracic inlet. It's very intimate with the anterolateral surface of the aortic arch and then disappears posterior to the root of the lung. This is our vagus nerve. Now, notice when they first enter the superior mediastinum, the vagus is medial to the phrenic. As they continue to descend in the superior mediastinum and reach the root of the lung, the vagus becomes more posterior and the phrenic becomes anterior, moving from a medial lateral relationship to a posterior anterior relationship. Let's look at a lateral view of these same structures and to better appreciate that anterior-posterior relationship. This is a right chest view. And here you see the root of the lung as it enters the hilum of the lung. With the bronchus being here, the very posterior structure, the pulmonary artery being the more superior structure, and the pulmonary veins being the inferior and anterior structures in the root. Remember, the pulmonary veins are going to be red because they're actually carrying oxygenated blood back to the left atrium. while the pulmonary artery is blue in the more superior structure because it's bringing the deoxygenated blood from the heart to the lungs. So anterior to the root, you see the phrenic nerve and pericardiaco-phrenic artery. Here, coming down the lateral aspect of the trachea to dive posterior to the root of the lung, we have the right vagus. On this side, we don't see a right recurrent laryngeal. So it branches very high, really before the vagus even enters the superior mediastinum. Here's the same image, but from the left side. And again, you can see anterior to the root of the lung, we have the phrenic nerve. Posterior, we have the vagus nerve. And you can easily appreciate that the left recurrent laryngeal is there dipping under the aortic arch. Remember, our vagus nerve is parasympathetic. It's going to be supplying parasympathetic fibers to the heart, the lungs, the trachea, the bronchus, the esophagus, and the abdomen. The phrenic nerve is going to be carrying motor and sensory fibers. C3, 4, 5 keep the diaphragm alive. So those are the roots that are going to be contributing fibers to the phrenic nerve. And it's going to be supplying sensory fibers to the pericardium, the mediastinal and diaphragmatic pleura, and the diaphragm itself. Not just the pleura covering the diaphragm, but the actual diaphragm. It also has motor fibers that it will supply to the diaphragm. Now, on the most outer aspect of the diaphragm, you do have a little bit of somatic innervation from the intercostals for sensory innervation, but the majority of the sensory innervation is going to be provided by this phrenic nerve. Let's look closer at these recurrent laryngeals. Cranial nerve 10 can be seen descending between the common carotid artery and the internal jugular vein. So those three structures will be wrapped in a carotid sheath. The artery would be medial, the vein lateral, with the cranial nerve 10 sandwiched between the two, but posteriorly between the two. So cranial nerve 10 is the most posterior structure in that carotid sheath. The right vagus descends between those structures in that sheath and then gives off the right recurrent laryngeal just before it enters the superior mediastinum by looping underneath that right subclavian artery. The left vagus is going to continue a little bit more inferiorly before it gives off that branch. It waits till it goes all the way down past the aortic arch and then gives off a branch. So notice these recurrent laryngeals are going to ascend and eventually be located medial to the common carotid artery. So the vagus is lateral to the common carotid, while the recurrent laryngeal is medial to the common carotid. It depends on what level you're going to be looking at this. If you take a cross-section through the superior mediastinum, you will only be able to see that left recurrent laryngeal. The right's already branched and begin to ascend. It doesn't really enter the superior mediastinum. So here's the image we looked at earlier with the heart removed. And this gives a better image of what the left recurrent laryngeal tract is within the superior mediastinum. So we follow the vagus as it descends in the carotid sheath with the common carotid artery and jugular vein. It moves laterally to the aortic arch and then passes left to right underneath that arch. You see a structure circled here in green. It's a little fibrous band. That's your ligamentum arteriosum, a structure from the pulmonary arteries to the aortic arch. So in prenatal life, this is an open structure that allows blood to shunt from the pulmonary artery to the aorta, so that blood can bypass the lungs. Because remember, before we're born, the placenta oxygenates the blood, not the lungs. Once born, the ductus arteriosus should close to form the ligamentum arteriosum. If it doesn't close, we have a PDA, a patent ductus arteriosus, which is bad. you have blood shunting around the lungs straight into the aorta without being able to be oxygenated. In your adult patient, you should be able to locate this passing from that pulmonary artery to the aortic arch so that you can find this left recurrent laryngeal nerve. So again, it's passing left to right underneath the arch of the aorta, posterior to that ligamentum arteriosum. Once it passes posterior to the ligamentum arteriosum, it recurs, as its name states, and begins to ascend now. Notice that it becomes very intimate with the trachea and esophagus. It actually travels in a groove known as the tracheoesophageal groove, the TE groove. And it'll be ascending all the way into the neck to help innervate our vocal cords. So remember when we talked about an aortic aneurysm in this area. This is another structure that could easily be compressed from the mass effect of that aneurysm. In that situation, you would see hoarseness because you're losing the innervation to the vocal cords. So let's look at this in a cross section just to bring it all together one more time. We know that this is the superior mediastinum. Why do we know this is the superior mediastinum? V, A, T, and E are all present. Remember, the trachea divides at the level of TV45 when the superior mediastinum ends. This area is indicating a nerve, but what nerve do you think that could be? Realize we're in that TE or tracheoesophageal groove. That makes this our left recurrent laryngeal. Again, remember with a cross section, your right is the patient's left. Also remember, we will not be able to see the right recurrent laryngeal at this level because it branches more proximally, looping under the right subclavian to go ahead and start ascending back into the neck, or to recur. What could this be then? We have two yellow structures there. This one's on the lateral aspect of the trachea. Do you remember who we said would be descending on the lateral surface of the trachea? The vagus nerve. And because that's our left, this is the patient's right, that's our right vagus nerve. And just anterior to the vagus, remember we have our phrenic nerve. Now the left phrenic and left vagus are seen here. There's our left phrenic, there's our left vagus, and they're separated from the trachea by the aorta and its branches. So you do not see the same intimate relationship with the left vagus and the trachea as you do with the right vagus and the trachea. Try to pause and label this image and see if you can pick out the different structures that we've gone through. Remember, this image has contrast, so the vessels will light up as white as well as the bone. The anterior border, the sternum, is seen here. You can kind of appreciate that the ribs are coming in to form that complete thoracic cage there. The thymus isn't visible really in the adult, so we'll move straight to our V, and that's going to be our left and right brachiocephalics. Remember, our left brachiocephalic is going to be the one crossing midline, while the right is just to the right of the sternum. You can see the right peristernal border and the right brachiocephalic vein line up really well. So this is just before the superior vena cava forms. Do you remember what level the superior vena cava forms? The first costal cartilage on that right peristernal border. So then we have A, but notice we have three different A's. So we're a little higher than the arch, and we're at our three main branches off of the arch. Medial to lateral, we have the brachiocephalic trunk, which will give us our right common carotid and also our right subclavian arteries. Moving laterally, we have our left common carotid artery and then the left subclavian artery. Next we have T, the trachea. And the trachea has those nice incomplete C cartilaginous rings that are going to help maintain a patent airway. So we see the nice open airway. Just posteriorly to the trachea we have E, our esophagus. Now esophageal lumen is much smaller and easier to collapse, and that's why you can't really see much of the lumen in this image. But you can see the thoracic vertebral body just behind that esophagus, making up the posterior border of the mediastinum. Before we end this session, let's talk about lymph just a tad. Lymph flows out of the lungs and into a collection of lymph nodes located around the tracheobronchial tree. The lymph nodes are going to be named for their location. So the inferior tracheobronchial nodes, also known as the crinal nodes, are located at the bottom of the trachea, right where it forms the main bronchus, at the carina there. Those will drain into the superior tracheobronchial nodes, which will then continue to ascend into the paratracheal nodes. And just as the paratracheal nodes name implies, they're located on the sides of the trachea. And all this lymph will eventually re-enter the circulation at what we will call the venous angle. We'll revisit that in part 2 when we talk more about the posterior mediastinum, but that venous angle is just going to be at the area where the subclavian and internal jugular veins merge to make that brachiocephalic vein. And you should now have a better understanding of the superior mediastinum. Stay tuned for part 2.